Thank you. I'm very grateful to Dr. Byers for the invitation to participate in this educational activity. And also very grateful to Dr. Ranjan Chetty and Diagnexia for supporting not just this educational webinar in English, but also for supporting and launching the series of educational webinars in Spanish with the target audience being Latin America and Central America, mostly Central America and South America. The title of my talk today is salivary gland carcinomas, a diagnostic approach. And I have the subtitle of communal and personal journey. And the reason why I chose to do that is because no individual pathology will know everything. Our knowledge resides in the knowledge that has been passed on to us by the people that train us in residency, and those of us that have done fellowship as well. Our interaction with current colleagues, not just in the hospital and setting where we practice, but also our interactions through professional meetings and more informal context as well. And there is also that knowledge that has been passing on by previous generations of pathologists with the models and concepts. So none of us will does practice in isolation. All of us have a variable degree of training and expertise, and their interaction with other colleagues, sitting down with other colleagues through a microscope, as in the past, or nowadays using digital pathology across the world, is of tremendous benefit, not just for us, but also for patients as well. Now, in the left side of the screen is the most common benign salivary gland tumor, and that is a pleomorphic adenoma. Those tumors have a very complex appearance that is variable. I liken that to cooking, for instance. I like cooking, and we have the basic elements, and the different combinations of elements that we see give us a dish. So in salivary gland tumor, understanding the components of the tumor, and that part becomes particularly important in difficult cases, it becomes of vital importance to arrive to the right diagnosis. And if it's not possible to arrive to a final diagnosis, at least provide a differential diagnosis, provide a grade if it's possible, and allow the clinicians, surgeons, radiotherapists to be able to tailor a specific treatment to the patient's needs. On the left side, in the right side, is a typical example of a tumor that probably we all know, and it's a very elegant appearance tumor. Is actually adenocystic carcinoma. Just in this picture, in this slide, you can see how different those tumors are. And the differences, although they are salivary gland type carcinoma or tumors, is in the elements that are part of the tumor, right? And that is the diagnostic approach that has been passed on to our through many generations. Now we can do more refined diagnosis now because we have ancillary techniques. First, we started with a special stains. Then we had immunohistochemistry. A new generation of antibodies are coming that allow us to refine the diagnosis. And let's not forget some of the concepts were based on electron microscopy observations. And now we're lucky enough to be in that era of molecular diagnostics. But remember, all of this came about because generations of pathologists pay attention to what the lesions look like and try to dissect the different elements and the way those elements are arranged in a particular tumor. And that's how we arrive at diagnosis. So in essence, our understanding of molecular biology had advanced the field, but that is based on a solid knowledge of light microscopy, but essentially is anatomic pathology, what we do in clinical practice, right? So my objectives today are mainly discuss a personal, and this is part of my communal journey. It's not just me, right? I learn from other people, and I modify it to meet my needs along the years of practice, right? My second and perhaps more important objective is to demystify the diagnosis of salivary and glands tumors, especially carcinomas, right? And I specifically say that because every time or multiple times that I open an article, the first couple sentences says the diagnosis of salivary and gland tumors can be difficult or is difficult. And as I used to tell my trainees, yes, it can be difficult, and part of the difficulty depends sometimes on the sample size, where you have less certainty about the diagnosis. But using a rational approach based on our knowledge, based on the architecture, based on the cellular component, we can arrive, as I said, if not to a definitive diagnosis, at least narrow the differential diagnosis that allows the patient to be treated appropriately, right? In addition to that, and we are lucky that we are practicing in 2025, we have multiple ancillary techniques. I already mentioned them. Immunohistochemistry, FISH, genes, all gene sequencing, depending where your practice is set. Having said that, we can always go back to morphology, and I have a diagram later on discussing that. I have a disclaimer. I have been a consultant to Diagnexia, but I have no other potential conflict to declare. So as I said, surgical pathology is a clinical specialty, right? And I suggest to residents, trainees, and everyone general is to actually pay attention to the clinical information. And I said that because when I started training, one of the things that quite often is don't get biased by the clinical information. Well, pathology is anatomic pathology is a clinical specialty. You need to know the gender. Why you need the gender? Because some tumors are more common in females, some more tumors are more common in males. And you can start narrowing that differential diagnosis. Age is important. Some tumors are, and most of carcinomas actually in salivary gland tumors are in older individuals, but not all of them, right? And some of the proportion or distribution of those carcinomas vary according to age, right? Symptoms are important. Pain is a very worrisome symptoms. Obviously, rapid growth, even in the presence of a tumor or a lesion that has been present for a long time, might point out to carcinomatous or malignant transformation of pre-existing pleomorphic adenoma. Lymph node. So as all of you know, this, especially the parotid gland has large number of lymph nodes. So in the differential diagnosis clinically, a lymphoma or metastasis is important to keep those in mind, because if the patient has a history of a lymphoma or resection of a melanoma or squamous cell carcinoma of the skin, that might be a metastasis, right? So those are symptoms and clinical findings that are important to keep in mind. Again, as I already mentioned this, the anatomic location. Some tumors, like salivary duct carcinoma, are way more common in major glands. Some tumors, like polymorphous adenocarcinoma, rarely, if ever, happen in the major glands. They usually are tumors of minor salivary glands and base of tongue. Other tumors like adenocystic carcinoma can occur as frequently in major glands as minor glands. But they are also quite common in nasal glands. And depending on location, the differential diagnosis of those lesions varies, right? Because there are other tumors, especially adenocarcinomas, that may resemble adenocystic, and one of those is the so-called HPV squamous cell-related carcinomas of the mucosa and nasal gland. As I already mentioned the previous history. So even before you actually get to see the biopsy, you have a lot of information to start narrowing down the differential diagnosis. Of course, even though anatomic pathology, surgical pathology is a clinical specialty, and we have to look at the slide. So, but again, with all the previous information that we had, now we can start dealing with a smaller differential diagnosis, right? So morphogenesis is a term that only it especially used to describe the salivary gland tumors, primary salivary carcinoma, that have a myoepithelial and basal cell differentiation, because those cells have a potential to grow in multiple shapes and phenotypes, right? And yet the way they mixture is essentially what may present difficulties, and especially for cytologies and for biopsies, right? Now, the next information that you have is architectural pattern, right? It's a solid. Some tumors are more common, rarely become cystic. It's a cystic. The cystic component is particularly important in the grading of things like mucoepidermal carcinoma. They have papillary differentiation. Polymorphous adenocarcinoma is one of those tumors, especially in the cribriform variant, that can have papillary architecture, right? Obviously, most of them will have ductal or glandular differentiation, and the typical cribriform pattern that we can see not just in adenocystic carcinoma, but also in benign tumors as well. So we had to put these elements together to arrive to a differential diagnosis. I already mentioned the participation of myoepithelial cells, and that is because they can have a spindle cell appearance. They can have a clear cell appearance, but you can, if you have access to immunohistochemistry, you can demonstrate that and narrow down your differential diagnosis. That tumor is purely myoepithelial, or do they have that dual component of myoepithelium and ductal glandular differentiation? Actinic cell, that is a very specific tumor, but they might be actinic cell differentiation in other, rarely in other salivary gland neoplasms. Mucous cells, squamous cell is one of those features that we see in many salivary gland tumors from benign, and it's actually quite common in pleomorphic adenoma. But what are the other cell components? How they are those cells arranged, right? And then we have the matrix deposition. Is the tumor generating that mitochondrial stomach? So you may have a basal cell adenoma. You may have a pleomorphic adenoma, or once you see a pleomorphic adenoma, is there a carcinomatous or malignant transformation, right? Does the tumor produce mucin? Then is a mucin in differentiation in a pleomorphic adenoma, you can see that, or is it an cystic carcinoma? So it's like looking at art, it's like looking at a painting. What are the elements that you see in that specific painting? So pathology is a very visual specialty, right? And we need to pay attention to those details, right? This is a diagram. This is taken from what is now a very old, well, not quite old, it's only 30 years old, atlas by Irvin Dardek, who was one of those people in the 80s, late 80s and 90s, who contributed all to understanding to the participation of myoepithelium in the different in the line of differentiation of multiple salivary gland tumors and salivary gland carcinomas, right? Here, so you have the basic structure, glandular ductal cells, and your basal and myoepithelial differentiation. You can quite often identify those two elements by regular H&E. Does the tumor have a predominant proliferation of myoepithelium and basal cell with a minor component of glandular cells? Adenocystic carcinoma would be the typical example of that. But not only that, the tumor can be a clear cell, a myoepithelial carcinoma, which is one of the rarest tumors. So you have a tumor, a carcinoma, with myoepithelial and ductal differentiation. So does it have clear cells? Then you may start thinking in epithelial myoepithelial carcinoma. But you have a framework to work those tumors. Criviform, you have it here, is the criviform pattern accompanied by glandular differentiation, and that's what is shown here. It's a pure myoepithelial basal cells. You have myoepithelial carcinoma, basal cell adenocarcinoma, basal cell adenoma, and so on. So now let's move on to the 2024 classification of salivary gland tumors. There is a long list, and the list keeps growing, right? And even probably it's not as long as lymphoma and some of the other organs, but it keeps growing as knowledge advances, as we use new technologies to classify tumors. We, as I said, become able to differentiate entities that in the past we lumped them together, right? But so that's what new techniques and science has allowed us. And more importantly, and I said this as someone practicing in Canada, it's collaboration, right? Many of these new entities tend to be relatively rare if we practice individually, right? But now one of the tremendous benefits of having digital pathology internet access is that now we're able to collaborate, and many of these studies have been using different techniques. The tumors are identified in Canada, but the molecular pathology work is done in the US and the UK, right? So science advances as we collaborate even more and more, right? So we have a newly described entity, very rare, but it is a new entity, striated duct adenoma. Based on molecular techniques, we say that the so-called sclerosing polycystic adenosis of the past, which is really rare, is actually more a benign neoplasm, an adenoma rather than some hyperplastic or reactive lesion, right? And these are rare lesions. So the steel pleomorphic adenoma and myopithelioma and basal cell adenomas and Warthin tumors are the most common lesions, right? But now we have a more refined classification. In the area of carcinomas, the usual entities are there, mucoepidermoid carcinoma, we know those. However, we have been able to identify new entities, microsecretory carcinoma, sebaceous adenocarcinoma, sclerosing microcystic adenocarcinoma. That category, salivary gland carcinoma NOS, has been narrowing and narrowing because we are able to identify other lesions that in the past we say, well, it's carcinoma, it's primary in salivary gland, and it's epithelial. So that is what happened to adenocarcinoma in the past, right? It becoming more and more rare, right? And then we have a mucinous adenocarcinoma that has been associated with AKT mutations, right? And again, these are rare lesions. So the problem for us most of the time are the more common category. That's what we're going to be running quite frequently in our practice, right? The other thing that the new classification, and this is not new, is that it really has solidified the role of molecular diagnostic techniques. But you'd really, depending on where you practice, you are able to make those diagnoses based on the previous, in the experience of other people, right? So you don't always have, we rarely, as I said, use molecular techniques, um, except perhaps we do it more of in consult cases, right? Because we receive a case from someone else who has a question and we want to provide an answer to those questions, right? But it's not something that is necessary for everyday clinical practice, right? The other thing has done is that I provide support to our impressions by light microscopy, based on light microscopy and immunohistochemistry, right? But as you see here, not in every tumor, we're going to identify the typical molecular alterations, and that might be a function of variants, and our techniques do not allow us to identify those variants. So this is a changing field, and it will change in the future. That's just the nature of science, and it's just the nature of medicine, right? In the past, and those of us that trained many years, I remember having discussion with staff, are you a lumper or a splitter? Well, now I say, well, it depends on the situation, right? If I don't have resource to any of these techniques, based on all the information that I have, then this is my best diagnosis. And perhaps in the future, as has happened to many of us, when we review and study cases for teaching or for research, well, define, oh, this is an example of this entity. Well, that entity didn't exist in the past, but now we're able to say this is a typical example of a polymorphous adenocarcinoma or a epithelial myoepithelial carcinoma. And molecular techniques over the year has confirmed that. But so it's a changing field and is what keeps pathology and medicine and science exciting, right? Okay, so this is a recap of what has been my approach, and it's not unique, right? This is not something that I invented. As I already mentioned, you have all the clinical information, you have including imaging studies. Now, especially in those places where we have access to the patient chart electronically, we can even see the imaging studies. And it's a good idea also to look at the patient chart. We don't have to go to the patient's ward to see what the clinical impression of the surgeon is, right? That allow us to, as I say, narrow the differential diagnosis and give us more confidence in the diagnosis we're providing. But again, as I said, that is just part of the of the clinical information, of the entire information that we have, right? Artificial intelligence is a bit like us in the sense that we gather information and provide it, and that information, we get closer and closer to the so-called truth, right? We never get there, but as long as we keep moving in the right direction, I think it's progress is being made. So we have a differential diagnosis. Do we need accelerated techniques? And which one, right? And that is essentially provided by the differential diagnosis we have. If we don't need immunohistochemistry, is a typical example. Issue the report and you're done, right? The report, depending on what the case is, if it's a parothectomy, well, if it's carcinoma, provide the grade and other prognostic features. That's what makes for a diagnostic, a complete diagnostic report, right? If you have doubts, so before you sign that report, and this can be very quickly, stop for a moment and ask yourself, the findings support my diagnosis? You go through it again quickly, depending on your experience and confidence. You say yes, issue that report. You say no, think again. You may have to rework that diagnosis, right? But give that pause before you press the button and sign out, right? Especially if you're dealing with suboptimal samples, right? And this is what I keep, issue the report, right? If you look at it again and you think there might be a different diagnosis, well, again, the thought process keeps repeating until you arrive at, again, to the clinical pathology report, right? If you don't have a definitive diagnosis, again, there are multiple factors there, right? It's a very rare entity. It's a very poor sample, right? It's not always the pathology's fault, right? If you get a small biopsy and you do immunohistochemistry and you're still not confident in diagnosis, it's okay to say this is a differential diagnosis, but that always keep in mind to be helpful, right? That is, to me, always a question. Do I issue a report that is going to tell the surgeon, to tell the clinician what to do next, even if the diagnosis, the report is not definitive, right? It happens and happen not uncommonly. And sometimes, as I said, it depends of, sometimes you don't have access to all the techniques that you need to narrow down that rare tumor, right? Now, the most common, let's move to specific entities now. The most common salivary gland type carcinoma is mucoepidermoid carcinoma. This really has not changed that much, right? And again, we go back to light microscopy. Mucous cells is one cell that you want to identify in this type of tumors. Again, it is a tumor that is more frequent in male glands, is relatively frequent, more frequent in females than in males, but it does happen in males. It can have a variable cystic component. So cytology might just report mucus and a few isolated tumor cells. So in some cases, But imaging, if you look at imaging, it can give it a report of a cystic neoplasm in parotid gland, right? So mucous cells, non-descriptive intermediate cells, those are these polygonal type of cells that are somewhat epidermoid squamous, but did not produce keratin, right? So remember, this is quite important. In 99, almost 100% of the cases, mucoepidermoid carcinoma is not a keratin-producing tumor. If you see keratin, you got to start thinking a different entity. Even the immuno tells you that there is a squamoid differentiation because high molecular weight keratin, P63, P40, all those markers are positive. But you have a lot of squamous cells. So rethink your diagnosis, right? It's also, you have the epidermoid cells. These are non-keratinizing cells. You can see those cell junction, very rigid borders. Many of them actually frequent, you can have clear cells and columnar cells. As you see, this is a tumor with multiple cell types, quite often cystic. It is a tumor that doesn't have basal cells. Myoepithelial cells. So if you do a smooth muscle actin and it turns out to be positive, again, time to rethink your diagnosis, right? This is a typical example of a mucoepidermoid carcinoma, low grade, because it's predominantly cystic. However, when you look at the wall of doses, you can see that there is a degree of complexity to that wall. The other thing that you notice, which actually happened quite often in mucoepidermoid carcinomas with a significant cystic component, has a papillary architecture. And those papilla might be short sometimes. This is another tumor. Again, microcyst. You can actually see the mucin. These tumors have also glandular differentiation. But as you can see here, you can see cells resembling dystrophic or mucous cells or goblet cells from the intestine. That is the cell that you want to identify in the context of epidermoid cell, non-descriptive polygonal cells. Immunohistochemistry can help you here if you have a small sample and you haven't sorted that out. But in general, if it's a resection, you probably don't need any other immunohistochemistry or mucin stain to arrive at the differential diagnosis. Now, we do see tumors that are typical mucoepidermoid carcinoma sending consultation to us, and that is good. If your degree of confidence, you want a second opinion, remember, there is a patient at the other end, right? So if you don't feel confident, you just search for a colleague, but it's not necessarily a tumor, and years and decades of molecular practice, we have making this diagnosis without the help of many ancillary techniques. In the typical cases, now there are some variants where you may even end up having to do molecular, and that is with tumors that they have very few cystic spaces, and every now and then you see something like this, a basal non-descriptor cell with a bit of mucus differentiation, right? And we have seen mucus differentiation in Warthin tumor, for instance. Are those mucoepidermoid carcinoma that just they haven't been recognized, or the mucinous adenocarcinoma we have, or mucinous adenoma, right? So in that case, the finding the mammal rearrangement can be useful in the differential diagnosis because the immunohistochemistry in this case is not really going to solve your problem, right? Because it's going to tell you in most cases what you already see by light microscopy, right? This is a mucoepidermoid carcinoma with a solid component. Again, every now and then you see those typical mucous cells, but you have to search hard. Now, the other thing that you notice in all these multiple examples of mucoepidermoid carcinoma, this is not a tumor with basal bluish looking cells. So all the other long list of adenocystic carcinoma, epithelial myocarcinoma, they don't even play a role in the differential diagnosis in tumor that look like this, right? So you would experience, and you don't even have to be and most of these tumors are diagnosed by general surgical pathologists. You can arrive to the diagnosis very quickly by saying, remember, this is not a type of basal cell, myoepithelial cell looking tumor. So this is the most common, made of large cells, relatively large cells, except this line of with mucus differentiation. And so it's not, in the vast majority of cases, this is not a difficult diagnosis. You can accuse me of being a so-called expert, and this is easy for me, but it's not going to be easy for a junior pathologist. That's why I said, don't panic. You might move through the differential slower because you don't see many of these lesions, but using your knowledge, observation, and putting the information together, you can actually arrive to a diagnosis, right? Here is another example with epidermoid cells, but you see that mucin there, right? This is another example with clear cells. And this is an example with a solid high-grade mucoepidermal carcinoma. They do exist. So there is, and that has been demonstrated by molecular techniques. Even though they can be rare, there is such a thing as a high-grade mucoepidermal carcinoma. The other thing to remember, if the tumor is producing significant amount of keratin, chances are that is a squamous cell carcinoma, not a high-grade mucoepidermal carcinoma. At first glance, in this picture, you may not see those mucous cells, but if you observe more carefully, and this is what I said, this is it's essentially a salivary gland tumors tend to be a very elegant, I would just use that word, type of tumor pathology because you have those elements, and if you observe them, you can actually start identifying those mucous cells. Perhaps, and this is what I said, depending on how confident you feel, all you need to do is a mucin, or you got your mucin and you go to mammal or whole gene sequence to identify the translocation. So this gives you more confidence in the diagnosis, right? Especially in those solid tumors, right? If you don't have access, it's okay, a differential diagnosis, because now you know you are dealing with a high-grade carcinoma, right? And there is, as I said, one of the beauties of digital pathology for those that have access to scanning is be able to scan and share the case with other colleagues, right? The next one is a salivary duct carcinoma. This is again, is a tumor of big cells. This is not a tumor of a small cell. It is way much more common in male. And here you have a ratio. So it's a diagnosis that is relatively uncommon as a primary carcinoma in female. It does happen, as I said, and the statistics bear that. But if you go in terms of frequency, it is relatively uncommon in females, right? Major salivary glands is the more common location, and is the most common carcinoma arising in the context of a pleomorphic adenoma, right? So just another caution, right? And this is a question that was often asked to me in a core biopsy. You're going to call it pleomorphic adenoma. How do you know it's not malignancy if you're not seeing the tumor? Well, based on the clinical information, based on the sample that I have, that is the best diagnosis I can provide. And in terms of frequency, and said, that's an example where you might be wrong due to sample size, right? But at least in my experience, it's impractical in every core biopsy of pleomorphic adenoma, put a disclaimer that malignancy cannot be excluded. Surgeons should be able to live with that and manage the patient appropriately, because even though pathology is, in most cases, the final word, sometimes it isn't, because sample, and something that over time you may be able to, especially if you practice cytology, right, that make that diagnosis of pleomorphic adenoma and move on. If it's a malignant tumor, that is probably the surgeon already known that, because the patient, the tumor has grown rather quickly. So experienced surgeons will know that. So I'm not advocating by having a relaxed attitude. I'm just saying in some cases you are limited by the sample, right? It is a aggressive carcinoma, has the worst of us adenocystic carcinoma with perineural invasion, coupled with a very rapid growth in many cases, and frequently patient present with lymph node metastasis. So that's important to keep in mind. Again, this is not a tumor of a small cell. These cells are big. They are deeply eosinophilic, high mitotic, as I said. So when you look at this, all those categories, basal cell adenoma, basal cell adenocarcinoma, anocystic, epithelial, myoepithelial carcinoma, you can remove that from the differential diagnosis. Adenocarcinoma NOS, poorly differentiated non-squamous cell carcinoma, those kind of things can enter in the differential diagnosis. But all those strange, uncommon salivary gland tumor, looking at just this is a high-grade tumor with big cells, they don't even figure into differential diagnosis, right? So pay attention to all those details. That's what we do in anatomic pathology, right? Cells are big, eosinophilic. Frequently you will have necrosis. It's another tumor that can have papillary differentiation. And in this case, you can see quite clearly extensive perineural invasion, right? But they have many of those papillary structure, and they can have apical snot, indicative of apocrine differentiation, right? Initially, when these tumors were initially described I believe in the early 80s, it was pointed out to their likeness to typical invasive ductal carcinomas of breast. But these tumors are more apocrine differentiation. So if you have access to immunohistochemistry, that can be quite useful, right? You can do androgen receptor, right? This tumor, unless they have a so-called in situ component, do not have myoepithelial cells, right? Now, this is a high power. Sorry, the component, the benign component, is not that clear here. But I'm always very wary of pleomorphic adenomas. Pleomorphic adenoma-like tumor with extensive hyalinization. That hyalinization has been associated they might be indication of a burned out pleomorphic adenoma that now has become malignant, right? So you start seeing extensive hyalinization in a pleomorphic adenoma. Beware, sorry, be wary of ruling out malignant transformation. Immunohistochemistry, I already mentioned, these tumors are frequently androgen receptor positive. And now clinicians, especially in many parts of the world, I'm asking this for to help in adjuvant therapy, right? And the same for HER2 amplifications as well, right? We do not have a specific scheme to like we have in Bruce to report HER2 new, but it's useful information to provide to the clinician if you have access to it. Now we move to a different category of salivary gland carcinoma. This is the category of tumors having ductal and basaloid myoepithelial differentiation, right? So this is a different group. They can be almost put in a different box, mental box or category, right? It's common. Adenocystic carcinoma is common. As I said, the distribution is wide. You can see in younger individuals in the 30s and 40s, and I have seen that as well. There are reports of tumors arising in children, but to be honest with you, I have never seen it right in children. But I didn't practice in a pediatric hospital, right? The proportion of the distribution varies according to the gland. So if you have a tumor in submandibular gland, even though pleomorphic adenomas are not uncommon in the submandibular gland, the proportion of adenocystic carcinoma compared with parotid increases, right? There's still pleomorphic adenomas, as I said, is more common, but that malignant category increases, right, depending on the gland, right? It can be seen sinonasal tract, palate, and initially PLGA, polymorphous adenocarcinoma was reported more often in the palate as adenocystic carcinoma. And over the years, as we became more familiar with that entity, then the proportion of adenocystic carcinoma has decreased, right? I already mentioned this several times. It's that typical example of a dual of bicellular differentiation. And the cells here tend to be smaller unless there is high-grade transformation. That is rarely happens, right? The three typical patterns, tubular, cribriform, and solid, which you can see in other tumors. And then the grading, and we started to get away from that, is, in the purpose of this talk is not to discuss grading, but just I'll mention as a part of the diagnosis. So this is the typical appearance of an adenocystic carcinoma. Cells, when you look at low power, tend to be bluish, right? It's a smaller cell type because the cytoplasm is scanty, so the bluish is the nuclear, the NC ratio is higher, right? You have this cribriform pattern that actually is not a true glandular differentiation. These are the glands here. Those little small spaces, right? And is scattered throughout the tumor, right? It's rare, the adenocystic carcinoma that is purely composed of ductal elements, right? Is very rare. And if you do additional sampling, you will essentially find a more typical adenocystic carcinoma, right? This is one of those with a prominent ductal differentiation. But as you can see here, the luminal cells, you don't have that bluish myxoid basaloid stroma. That is actually part of the stroma rather than secretion by the ductal cells, right? And here you can see that you don't, in a typical case like this, you really don't have to use immunohistochemistry. As I said, immuno will provide further evidence that your diagnosis is the correct one. But if you don't have it and you have the typical tumor, you don't really need to resort to additional stains, right? So remember, it's context dependent. And over the years, I kept emphasizing more and more is, what is the context, right? And that gives you, it helps you with your thought process, right? So you have this, look for the typical cruciform if you're feeling unsure. But this is part of the spectrum of those tumors, right? And it might come in in a core biopsy, right? So that might be the contact that you have, and then you need immunohistochemistry at least to narrow down that differential. Again, another example of a tubular adenocystic carcinoma. Here, these are the true glandular cells. This is the stroma. This is that myxoid-looking basal lamina, which over time might become hyalinized, right? But the true glands are these, right? The other thing that adenocystic carcinoma does quite frequently is that myoepithelial cells has a sort of vaguely stellated, it's almost spindle appearance. And it becomes clear, right? And you see it here. So I don't see the clear cells often described as a component of these tumors, but it's because the cells tend to be small, and we pay more attention to these basaloid hyperchromatic nuclei rather than the clear cell component. But as I say, you see that ductal differentiation here, your differential diagnosis narrows down. And this to me was always a very worrisome sign in tumors, in small biopsies that I might be dealing with adenocystic carcinoma, especially when you start seeing that hyalinized stroma as well, right? Immuno, very helpful if you had this pattern, right? Because it confirmed that dual cell differentiation. This is a high-grade carcinoma with starting to have a solid component here, and here you can see those microcysts and more deep, those cribriform areas become more microcystic, right? But then again, here you notice that is a high NC ratio. Those tumors tend to be bluish, right? Perineural invasion, very frequent, and I suggest that if adenocystic is in your differential diagnosis, even in small biopsies from minor glands or core biopsies, you do look for this because this, if you see it, at least you can say this is a carcinoma, right? Immunohistochemistry, as mentioned, very helpful. Luminal cells, and not exclusively luminal cells, but also to some degree the myoepithelial cell would be keratin 7 positive. CD17 is predominantly expressed by the ductal cell. Your actin indicating the presence of myoepithelium. And even though they might not appear as a highly mitotically active, those tumors can tend to have a tendency to have a high proliferative index, especially in those solid areas. Immuno, if you have access to it, can confirm the diagnosis if there are doubts, or if you really want to really provide a definitive diagnosis. But in reality, most of the time, we actually didn't use it, right? Now, this is another example of a tumor like adenocystic carcinoma that had that dual component of ductal cells and myoepithelial cells. It is rare. It is quite rare, right? But it can be difficult to identify in a small sample. But I'll show you some H&E pictures to see how different this tumor, especially in resection, can look from adenocystic carcinoma. You have your ductal cells, but here the myoepithelial is plumper, so it doesn't have that spindle stellated appearance of the clear cells that you see in adenocystic carcinoma. By immunohistochemistry, these tumors are going to show similar phenotype because these cells, ductal cells, are going to be positive for a luminal ductal phenotype, and the outer clear cell is going to contain lots of glycogen and is going to express things like actin, S100, P40, P63 as most basal myoepithelial cells do, right? But the appearance with that prominent plump, larger clear cells in the external layer really is the clue to the diagnosis. So similar component, theoretically different, but different appearance, right? And rarely this tumor will have high-grade transformation. The importance of reporting high-grade transformation is the frequency of lymph node metastasis to the next increases, right? And some of these tumors may even present with lymph node involvement as well, right? So it does have prognostic and management implications. This is what I was mentioning to you about immunohistochemistry, CK7, P63, but the positive reaction is different, is seen in a different context from adenocystic carcinoma, right? So the phenotype immunohistochemistry, as we know now, one has to interpret it in the context of the appearance of the tumor. I think it's 10 a.m. already. I didn't cover some of the other entities. I'm happy to do it in the future. So I'm going to move to the last slide. That is my name. And if anyone has questions and they feel that I can help them with those questions, that is my email address, current email address. So that's an example of metatypical adenocystic carcinoma with a squamous differentiation. So it does happen, rare, but it does happen. So thank you.
Thank you very much, Bayardo. I think I'd say Richard's gone to his next meeting, but that was fantastic. And thanks so much for taking the time out to speak and present today. And yeah, that's everything. I think we'll let everyone go about the rest of their day.
Do we have time for any question? I don't know if there is any.
Yeah. So if there's any questions, if anyone wants to raise their hand or put them in the Q&A, more than happy to read them out so that we can answer them.
And you can email as well, as I said.
Yeah, no problem. See if there's any questions, guys. Just checking the chat and the Q&A. There doesn't seem to be anything at the moment. Last chance. I'm sure you'll receive some emails, Bayardo. Sometimes I think it's a bit intimidating asking questions on the webinars.
Yes, no, it's I've been in this situation. Do I have a question? maybe somebody else will ask the question that is in my mind, and I
Yeah.
should know the answer to that question. So I don't want to appear like being the ignorant person. But anyway, there are multiple reasons for that.
Yeah.
Um,
Okay.
I,
Well,
thank
I
you
think
very
we'll leave it
much.
there for today. No,
Yep.
thank you very much, Berto. Have a lovely day and enjoy the rest of your week.